Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's September 2023 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice this month is a review article entitled Guess What We Can Hear? Novel Voice Biomarkers for the Remote Detection of Disease. It is authored by Dr. Jess Serra and colleagues from Mayo Clinic in Rochester, Minnesota, and colleagues from Tel HaShomer and Tel Aviv in Israel. Our speech is not only a needed vehicle for communicating, but in its word choice, verbal structure, cadence, pronunciation, pitch, among other features, so often says who we are. Indeed, made more than 2,000 years ago, the famous statement of Socrates, "Speak so that I may see you," recognized that speech goes beyond personal communication to afford insights regarding an identification of the speaker. But can our speech go even further to reveal the presence of an underlying illness? In the present issue of Mayo Clinic Proceedings, Serra et al. Superbly review compelling evidence that it can, specifically outlining the innovative diagnostic capability and utility of voice and speech data when analyzed by artificial intelligence and machine learning. These authors discuss how such analyses of linguistic and acoustic characteristics of voice and speech can detect voice biomarkers that, if you will, bespeak disease processes. Speech is determined by the laryngeal, respiratory, neurocognitive, and neuromotor systems all acting in concert, and is influenced by the mental state and by cardiovascular, endocrine, and immune systems. The authors survey the increasing body of literature which demonstrates how analyses of voice and speech can detect cardiovascular diseases, neurologic disorders, infectious diseases such as COVID-19, and psychiatric conditions. Indeed, the seminal studies of these authors some 5 years ago in this journal established an independent association between specific voice biomarkers and coronary artery disease. In their present review, the authors introduce a novel classification of voice biomarkers based on 4 considerations: source of vocalization, methods of voice assessment, and those of voice analysis, and location of analysis. Serra et al. Outline how voice biomarkers may be developed from recordings, how acoustic and linguistic characteristics may be gleaned, and the application, training, and testing of relevant voice algorithms. In this process, they emphasize the importance of quality control, verification, analytic validation, and clinical validation. They also emphasize the importance of prospective clinical trials in this field and the need for strategies that ensure data protection and individual privacy. Finally, Serra et al. Appropriately underscored the particular utility of voice and speech analysis for disease detection in telemedicine, a rapidly growing form of healthcare delivery that does not require face-to-face encounter. In this regard, the statement of Socrates is uncannily prescient, as it says that our speech, by itself, allows others to see us. Our first highlight article this month is an original article entitled Renin-Angiotensin-Aldosterone System Inhibitions and Cardiovascular Outcomes in Myocardial Infarction with Renal Impairment. It is authored by Dr. Seok Oh and colleagues from the Department of Cardiology at Cheonnam National University Hospital in Gwangju, Korea. Therapeutic strategies for secondary prevention after an acute myocardial infarction include inhibition of the renin-angiotensin-aldosterone system by angiotensin-converting enzyme inhibitors, ACE inhibitors, or angiotensin receptor blockers, ARBs. A question that arises is the effect of inhibition of the renin-angiotensin-aldosterone system following acute myocardial infarction in the setting of renal impairment, as there is a bidirectional relationship between acute myocardial infarction and kidney disease. Kidney disease is a risk factor for acute myocardial infarction, and acute myocardial infarction may compromise kidney function. A corollary is the issue whether there are differences in outcomes when either ACE inhibitors or ARBs are used in this setting. O et al. Compared the relative outcomes of the use of ACE inhibitors and ARBs in patients with acute myocardial infarction with renal impairment. The patient population analyzed was derived from the Korean Acute Myocardial Infarction Registry, National Institutes of Health, and whose data were entered in this registry between November 2011 to December 2015. These patients were followed for 3 years after the index hospitalization. The primary endpoints were major cardiac and cerebrovascular events, and this included all-cause mortality, non-fatal myocardial infarction, revascularization, rehospitalization, and stent thrombosis. The main finding from this study was that treatment with ARBs compared with treatment with ACE inhibitors was associated with a significantly higher incidence of major adverse cardiac and cerebrovascular events on the unadjusted analyses and analyses that employed propensity score matching. However, in the propensity score matching analysis, there was no significant difference in revascularization or rehospitalization between the two treatment groups. In the unadjusted analysis, patients treated with ACE inhibitors compared with those treated with ARBs had lower all-cause mortality with an eGFR in the range between 15 to 90 mL per minute. When propensity score matching was employed, all-cause mortality was lower in patients treated with ACE inhibitors compared with those treated with ARBs in the more limited eGFR range of 60 to 90 mL per minute. To explain the better outcomes generally observed in the ACE inhibitor-treated group, the authors point out that ACE inhibitors, unlike ARBs, do not activate receptors such as the angiotensin II receptor type 2 and the angiotensin II receptor type 4, both of which may lead to adverse vasculopathic effects. Additionally, ACE inhibitors stimulate the production of bradykinins, which generally exert a vasoprotective effect. The authors emphasize the need for prospective clinical trials to further examine these intriguing findings derived from studies based on real-world data. Our second highlight article this month is an original article entitled Vascular Graft Infection After Aneurysm Repair, a population-based study. It is authored by Dr. Hassam Tabaja and colleagues from Mayo Clinic in Rochester, Minnesota. Vascular graft infection after aneurysmal repair is a potentially life-threatening complication. Tabaja et al. Predicated their present study of this issue on the following considerations. First, the use of synthetic grafts decreases the incidence of aneurysmal rupture, but such synthetic material increases the risk of infection. Second, the introduction of endovascular aneurysm repair facilitates the treatment of patients who may be at a high risk for complications following open surgical repair. But similarly, the use of synthetic stents in endovascular aneurysm repair also poses an infectious risk. Third, there are very few studies of vascular graft infection that are population-based, as the bulk of data pertaining to the risk of vascular graft infection is derived from institutional observations, the latter being subject to bias. Tabaja et al. Employed the Rochester Epidemiology Project to examine the occurrence of vascular graft infection in patients from 8 counties in southern Minnesota who underwent aneurysmal repair at Mayo Clinic, Rochester. The study population included those in whom either grafts in open surgical repair or stents in endovascular aneurysm repair were used to repair aneurysmal dilatation, with the term graft including both grafts and stents. The patients studied included those with aneurysmal dilatation involving the thoracic aorta, the abdominal aorta, and large arteries such as the iliac, subclavian, and others. Of the 643 patients studied, 15 developed vascular graft infection, with most cases occurring after several months. The 5-year cumulative incidence rate was 1.6%, with the incidence of vascular graft infection being comparable in open surgical repair and endovascular aneurysm repair. Fistulas to the respiratory and gastrointestinal tracts were rare. Vascular graft infection was diagnosed by blood cultures, markers of inflammation, and imaging, as very few patients underwent aspiration of the perigraft fluid. Patients were generally managed conservatively. 10 deaths occurred after a median follow-up of 6 years. From these data, the authors underscore that in this population-based study, the incidence of vascular graft infection is low, but all-cause mortality after vascular graft infection was substantive, the latter likely reflecting an older patient population with an increased prevalence of cardiovascular and other comorbidities. You can access these highlights and editor's choice articles free of charge during the entire month of September. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And you will see other free content as well as articles published online in press. You will also find links to our social media by clicking the buttons at the bottom of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our websites also includes our Mayo Clinic Proceedings issue summary and Author Insight podcast recordings, which are available from our website on the home page as well as through iTunes. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.